Hello and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on Clostridium tetani. So this is a picture of Clostridium tetani. As mentioned previously, it is not common practice for the membership exam to give you these pictures and histology slides and asking you to identify the bacteria. However, they are completely within their rights to ask you this question as part of your Part 2 written examinations. Therefore, I strongly recommend that you try to put this into memory and have a rough idea of what the bacteria would look like under the microscope. So, as far as epidemiology, it is rare in developed countries due to widespread vaccinations. It has a higher risk in older adults, neonates, and in developing countries, and in those individuals who are not immunized. It is ubiquitous in soil and animal feces. The pathophysiology of Clostridium tetani is that it's an anaerobic gram-positive spore-forming bacillus. It causes tetanus, which is a neurological condition characterized by muscle spasms. Spores can enter the body through wounds where they germinate. It can produce tetanospasmin, which is a potent neurotoxin. This blocks the neurotransmitter release from the inhibitory neurons, causing muscle spasm and rigidity. The toxin bind is irreversible. The clinical manifestation is really quite classic and key in trying to identify the offending agent. The incubation period is 7 to 10 days. However, it can be 3 days to several weeks. It is normally divided into two groups. One is generalized tetanus, which is the most common form. It causes trismus or jaw lock, stiff neck, difficulty swallowing, and rigid abdominal muscles. However, it can also present in a form of a localized tetanus, which causes persistent contraction of muscles at the infection site. It can also present as cephalic tetanus, which is really rare, and it involves usually the cranial nerves. And finally, it could present only in neonates, which is termed as neonatal tetanus, which is in the newborns through infection of the unhealed umbilical stump. So this is a picture of Opisthotonos in a person with tetanus that is really quite classic in terms of medical history. The management of this bacteria is through penicillin G, which eradicates C. tetani. The tetanus immunoglobulin, or TIG, is used to neutralize the unbound tetanospasmin. The muscle relaxants, such as diazepam, are frequently used for symptom control. And as always, if you're dealing with a disease that could potentially affect the respiratory system, maintenance of airway and respiratory support would be crucial. Also, nutritional support and management of autonomic dysfunction is key. Surgical debridement of the infected wound is also used to remove the source of the spores. The prevention of this is done through the vaccination, which vaccinates against diphtheria, tetanus, and pertussis. Let's do some questions. Question 1. A 30-year-old construction worker presented to the emergency department with difficulty opening his mouth and stiffness in his jaw and neck. 2 weeks after sustaining a minor laceration on his leg at a construction site. He has not received any immunization since childhood. Over the next few hours, he develops a spasm in his facial muscles and Opisthotonos. Which of the following best explains the mechanism of the symptoms? A. Inhibition of acetylcholine release at the neuromuscular junction. B. Activation of inhibitory glycine receptors in the spinal cord. C. Blockade of inhibitory neurotransmitter release in the central nervous system. D. Direct toxin-mediated neuronal damage. E. Activation of excitatory N-methyl-deaspirate NMDA receptors. And if you were listening to our previous slide, you would realize that the correct option in here would be option C, which is the blockade of inhibitory neurotransmitter release in the central nervous system. Thanks for listening to this episode of Bite Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.